Hello everyone and welcome to my presentations. By the end of this presentation, you should have more understanding broadly of forensic mental health nursing. By the end of this presentation also, you should have more understanding of mental health disorder offender and how to care for this group of clients. The target audiences that I hope to be benefit from my presentations are students, mental health clinicians, general public who may benefit from this presentation. The aim of this presentation is to understand the relationship between psychotic illness and violence, to examine the current practice in the assessment, to identify the risks, protective factors that form management plan. We're going to explore and examine current research related to the concept of psychopathy and diagnosis such as antisocial personality disorder, violence and aggression management plan. Going to examine current research related to mental health of prisoner, provision of treatment for mental health disorder offenders. Presentation topic is summarize the main core of this subject, forensic mental health nursing. This presentation will give target audience an overview of mental health disorder offender to understand the reasoning lead to their presenting problems. Add to that, this presentation will give intervention strategy that can be used when care for this group of clients. Am I born this way? Environmental genetic factors are two factors that contribute to mental health illness. Key terms. Antisocial is a mental condition in which a person has a long pattern of manipulating, exploiting, violating the rights of others. Psychotic, mental problems that cause people to perceive or interpret things differently from those around them. They have problems to differentiate what real or what not. Psychopathy is traditionally a personality disorder characterized by persistent antisocial behavior, impaired empathy, and remorse. Criminality, the state of being criminal or criminal activities. Mental health disorder offender is a term used when someone has committed crimes, when they are proven to have mental health illness. Criminal justice system, in this context, in this presentation, we refer to the court, correction, the police. Firstly, we're going to explore the relationship between psychotic illness and violence. Psychotic, the state of having difficulties determining what is real and what is not. Psychosis is a mental disorder where a person lost capacity to tell what is real and from what it isn't. They may believe or sense things that aren't real and become confused or slow in their thinking. Psychosis often occurs as a part of mental health illnesses. However, it is treatable. Psychosis can be transient or can be chronic. Psychotic clients can experience hallucination, delusion, and disorganized in their behavior and their thinkings. Violence and aggressions. Violence and aggressions are behaviors that are intended to harm and are directed toward others. There is a correlation between psychosis and violence. However, not all violent people are psychotic. It is found that the people who do not have psychosis are repeatedly highlighted anger as a factor in participating actual physical violence. Only a minority of patients who have schizophrenia or other psychotic symptoms engage in violence, not at all violence by people with schizophrenia. Paranoid ideation has strong link to violent behaviors. There appear to be consensus that the rate of violence are higher in people with a diagnosis with schizophrenia compared with general population and other psychiatric group. A paranoid belief that other intended harm is one psychotic symptom that might contribute to aggressive behavior. Violence and aggression in people with schizophrenia most often occur during the periods of active or untreated psychosis. Drug-induced psychosis has strong link to violence ideation. Individuals who developed persecutory delusion were significantly more likely to be violent. Persecutory delusion significantly mediated the association with untreated schizophrenia and violence. It is the myth that all psychotic people is violent. In fact, people being treated with psychotic are no more likely to be violent than anyone else, but they are more likely to be victims of violence. We had some understanding of psychotic illness and violence. Now we're going to move on to psychotic illness and violence assessments. We will examine of the current practice in assessment. The first assessment that we are going to looking into is the MacArthur-Modesley assessment of delusion schedule. Delusions are firmly held felt belief. They are associated with a number of disorders, including schizophrenia, delusional disorder, but can also be found in the patient with affective disorder or dementia. MacArthur Violent Risk Assessment study utilizing a different methodological approach to investigate association between specific delusion and violence. Serious violence was established using the MacArthur Community Violence Interviews. Cognitive and Functional Assessment of Psychotic Certification Study. This assessment covers a wide range of participation history, life stressor, trauma, family history. It assesses patient cognition, social perception, memory, learning, attentions, executive function, and general cognitions. It measures to assess psychosocial function and quality of life, psychotic symptoms, severity, clinical course of illness, and parameter for advised medical outcomes. Behavior and symptom identification scale. This assessment used 24-item self-report instrument with 6 scales: psychosis, depression, functioning, interpersonal problems, alcohol, drug use, self-harm, and emotional lability. Symptom checklist 90 revised. Symptom checklist 90 revised use 90 items self-assessment tool that measure psychoticism and paranoid ideation in addition to 7 other symptom scales. Brief symptom inventory. Brief symptom inventory use 53 term self-administered scale developed from SCL-90R. This assessment had good psychometric properties that is an acceptable brief alternative to the SCL-90Rs. Mental health status examination are commonly used in authorized mental health setting. It also assesses level of risk of clients in terms of aggression risk, absence without permission risk, self-harm risk, and vulnerability risk. Understanding mechanisms through which people with schizophrenia progress to actual acts of violence is therefore important to assessing and managing the risks. We have touched on a little bit of risk assessment in previous slides. Now we're going to have more understanding of the risk assessment, management, psychotic illnesses, and violent aggression behavior. Potential risks, current risks has to be included in risk management plans. It is helpful for clinicians to form some sort of risk management prior to contact clients. The information of the risks can be accessed by the handover, clinical incident, clinical report, nursing report, patient notes, and online database. It is essential for clinicians to identify the risks and protective factors. Risk assessment and management should be conducted regularly. For example, if the client's discharged, risk assessment should be conducted. It is also important if the patient moved to other ward or unit, risk assessment should be conducted. The reason for that is to give other clinicians in other units to understand the whole picture of the patients and current risks of the patients. Therefore, they can deal with clients accordingly. It is a requirement for clinicians who look after for the clients on that shift to conduct risk assessment on the clients. To conduct risk assessment, clinicians should understand clients, the trigger, the risk, protective factor that need to be identified, the risk factors, hostile behavior, recent drug misuse, compliancy, impulsivity, recent alcohol misuse, client forensic history, client's aggression history, protective factors, education, employment, compliancy, insight and judgment, new aggression history. For example, if the patient have no aggression history, this therefore is a good indication telling clinician that clients is more likely to comply with the treatments. However, clinicians still need to continue to assess aggression risk in the clients who had no history of aggression to ensure that there is no other underlying factors. It is important to understand client diagnosis, therefore we can look after clients accordingly. DSM-5, the Diagnostic Statistical Manual Mental Disorder, is reference manual mental health professional and clinician use diagnose mental health disorder. DSM-5 is widely used in authorized mental health setting. Alternatively, ICD criteria can be used. ICD-10 is an international statistical classification of disease and related health problems. We can also use cognitive behavioral approach CBT for psychosis and aggression. This method is a short-term goal-oriented psychotherapy treatment that takes a hands-on practical approach to problem solving. Its goal is to change patterns of thinking or behavior that behind people's difficulties, and so change their way of they feel or the way they act. Reasoning is a process of determining right or wrong in a given situation. According to American psychologist Roland Cuthbert, people develop through 3 levels of moral reasoning as needed by situation they encounter. The lowest levels of developments involve making decisions of morality based on the prospect of punishment. A person don't do such a thing because consequences. At the second level, a person perceives an absolute right and wrong and believes the law is the judge and morality. The highest level, a person makes moral choice based on social contract, unspoken agreements to behave a certain way, and when they can generalize ethical principles beyond their own interests. Collaborative client-centered counseling. These methods use client-centered care. These methods allow clients to be involved in their care. It encourages client autonomy. Medication interventions. Medication interventions such as oral benzodiazepine or oral antipsychotic, intramuscular medications, as well as acute short-acting antipsychotic medication. Involuntary treatment can be applied if the patient had low level of compliance. The last resort is seclusions. If other intervention has failed, seclusion is considered. However, the clinician needs to ensure all the elements have been looked at, for example, legal or ethical. The clinician to decide what kind of method will be best for the situation. At the end, the best interest of the patient should take precedence. We're going to move on now to one of our interesting topics, psychopathy. We are going to explore and examine current research related to the concept of psychopathy. Psychopathy is traditionally a personality disorder characterized by persistent antisocial behavior, impaired empathy and remorse, a blood, disinhibited, and egotistical traits. Psychopathy is a personality disorder describes individuals with specific of the trait. Grandiose, self-centered, aggravated, sense of self-importance, inflated self-esteem, blame others for their own failure, callous and cold, irresponsible. What good about psychopathy? Psychopathy is embedded in our society. Psychopathy can do very well in business and even entry to politics. As you might have noticed, a lot of politicians around the world have some psychopathic personality traits. Why are they doing well? Because they are charming, easy to make friends, doing well in business, they are fearless, they're good at lying, very confident, good at manipulation, goal-oriented, and social assertiveness. What's dangerous about psychopathy? Psychopathic had no remorse or little guilt, lack of social concern, lack of empathy, shallow emotional response, usually display poor impulse control behavior, engage in criminal activities, alcohol and drug dependency, love taking risks and high sexual drive. They are spending big and live high lifestyle. They have grandiose sense of self, low fear including state tolerance. Are they born that way? Environmental and genetic factors are two key factors that contribute to psychopathy. It can be diagnosed alone, but can be diagnosed under mental health illness, such as antisocial personality disorder, by using the DSM-5 and International Classification of Disease (ICD). Psychopathic characteristics are widely used in criminal justice system. The study have found that psychopathy score correlated with repeated imprisonment, detention, higher security, disciplinary infraction, and substance misuse. Studies have suggested that a strong correlation between psychopathy and criminal activities. Psychopathy has strong correlation with sexual crime, sexual murder, child molester, sadistic violence. Study found learning impairment in psychopathy and dysfunction in frontal cortex. Psychopathy has been associated with abnormality. Both genetic and environment factors are to believe responsible for psychopathy. We're going to move from psychopathy to antisocial personality disorder. Poor mentalizing has been described as characteristic of antisocial personality disorder. There is a strong link between antisocial personality disorder and criminality. Antisocial personality disorder displays the pattern of antisocial and aggressive behavior at beginning during childhood and remains stable throughout life. Lifelong patterns of poor self-control ability, impulsivity, and risk-taking behavior are prevalent in those suffering from antisocial personality disorder. Antisocial personality disorder is one of 6 personality disorders stated in Diagnostic Statistical Manual of Mental Health Disorder 5th editions. The essential feature of antisocial personality disorder in dimensional model are antagonism and disinhibition. Antisocial personality disorder has strong link to criminal activities. Reportedly, 47% of male prisoners has been previously diagnosed with antisocial personality disorder. It also found most violent crimes were committed by a small number of men with antisocial personality disorder. And scan found multiple brain structure that difference in antisocial personality disorder. Free tonal gray matter volume in antisocial personality disorder was reduced by about 11%. White matter fractional antistrophy decreases in the right frontal lobe in antisocial personality. Violent individuals diagnosed with antisocial personality suffered from significant loss in the anterior convoluted volumes. It is shown that white matter fractional antistrophy decreased in the right frontal lobe in antisocial personality disorder. Diagnosis and treatment antisocial personality disorder. According to DSM-5, antisocial person disregarded for and violation of other rights since age 15, as indicated by one of 7 sub-features. Failure to obey laws and norms, lying, deception, and manipulation. Impulsive behavior. They can be irritable and aggressive, violently disregard safety of self and others, irresponsible, lack of remorse. To date, there is no effective treatment method such as for antisocial personality disorder. However, there are some suggestions of treatment that can be moderate the symptoms. Medication, for example, benzodiazepine. Benzodiazepine can be used when the patient is high risk of aggression or mood disturbances. Mindfulness, such as meditations. Psychotherapy treatments. Cognitive behavioral therapy. Schema-focused therapy. Electrical behavioral therapy. Psychodynamic psychotherapy, totalization-based treatment. Mindfulness defects were associated with antisocial personality disorder trait, and a significant unique association emerged between difficulty in acting with awareness and antisocial personality disorder trait. Likewise, physical aggression confirmed its association with antisocial personality disorder trait. Moderation analysis revealed that mindfulness interaction with aggression in predicting antisocial personality disorder. Specifically, a low level of mindfulness dissociation between aggression and antisocial personality disorder dropped to non-significance. Violence and aggression management. Now we're going to talk about strategy and skill to more effectively engage with the person presenting with hostile, angry, or out of control. Aggression and violence in mental health service is far too common. The problem affects staff physically and emotionally and contribute to low rate job satisfaction. It is affecting staff psychological well-being. It is also increased stress anxiety level. Physical intervention skill can be used such as restraint, breath away, occupational violence preventions, verbal de-escalations. Clinicians should assess patient risk of aggression prior to use verbal de-escalation skill. The reason for that is the clinician could put themselves at risk while the patient is high risk of aggressions. Active coercive techniques such as seclusion, rapid tranquilizations such as intramuscular medications. Interpersonal technique including de-escalation. Aggression and violence resulted in staff absence, legal security, and reduced productivity costs. It is suggested that an increase in interpersonal over-coercive technique will lead to reduction in physical intervention and violent incidents. Prevention and management of aggressions of violence had been viewed by the nurses working in secure and forensic settings as one of their key roles relative to their colleagues in acute mental health services. Hands-on and hands-off management. Hands-on management approach including physical, pharmacological management. Hand-off management approach including no intervention, de-escalating interventions it currently are using in mental health setting. Mental disorder offenders. Mental disorder offender is a term used when someone has committed a crime when they are proven to have mental illness. It is worth noting that mental health illness is not linked to criminality. People with mental health illness are likely to commit crime at the same rate as people who are not. However, issues that rise when people with mental health illness come into contact with criminal justice system. There is assumption that a high proportion of people with mental health illness commit crime. However, this is not the case. People with mental health illness comprise disproportionate number of people who are arrested, who come before the courts, and who are imprisoned. People with mental health illness comprise a disproportionate number in the people who are involved in criminal justice system. Lack of thorough mental health screening in criminal justice system lead to incarceration among people with mental health illness. Therefore, mental health illness people have not been treated properly prior to incarceration. Mental health illness was 80% in prisoners as opposed to 31% in community. The institutionalization of mentally ill has strong link to homelessness. Mentally ill clients ended up on the street due to lack of social support, proper transition to community, for example, education, training, and housings. The law provides that unsoundness of mind is different to criminal charge. Application to the laws mean some persons charged with criminal offense are judged not fit to enter plea or are found not guilty because mental disorder and become forensic patients. Within Australia, Queensland is only jurisdiction have established a mental health code which determine mental responsibility issue, insanity defense for the defense of diminished responsibility, inadequate treatment, and prison-induced insanity. Persons with mental health illness often require assessment and treatment to break the cycle of recidivism. However, prisoner mental health assessment had been arguably inconsistent following intake. No jurisdiction have any formal ongoing assessment or scanning service that monitor prisoners. Individuals with a history of incarceration were more than twice as likely to report experiencing mental health illness. Ex-prisoners also reported substance use at most 5 times of incidents of people who had never been in prisons. Incarcerated affective disorder at more than 3 times, and anxiety disorder at twice the incidence of those people who have never been incarcerated. Many people who suffer from a mental health illness are not suitable for community work or home detention, with leave jail as the only option. Mental disorder offender is the main call for forensic mental health nursing. Prisoners experience major mental health disorder 2 or more times more expected rate in the community, with substance abuse, personality disorder being overrepresented. New South Wales research has suggested up to 67% of prisoners will reoffend within 5 years of release. Mental health problems are more common amongst female prisoners than male prisoners. Female prisoners are more likely to present with mood disorder, anxiety, phobia, post-traumatic distress, and obsessive-compulsive disorder. Male prisoners are more likely to present with conduct disorder, attention defective, hyperactivity disorder, substance abuse, and learning disorder. Original offenders demonstrate high rates of mental health problems and alcohol and drug dependency. Forensic mental health claims. The law provides that unsoundness of mind is a defense to criminal charge a person found not guilty because mental disorder and become forensic patients. Mental health courts and court liaison service. In New South Wales, a court liaison program was established in 2002 to provide mental health assessment and referral service to magistrates throughout the state. The court may decide divided the clients to the hospital for mental health treatments. Therefore, forensic clients will be treated in inpatient setting. Divided the clients to community care. For example, forensic clients will be cared for in community setting. However, forensic clients will be closely monitored. The court may also decide to refer the clients to custodial mental health service in accordance with magistrate orders. For example, forensic secure unit. The court is not bound by the rule of evidence and may form itself in any way it considered appropriate. It may order examination by psychiatrists and other health professionals. It may make forensic order to provide for treatment in mental health system. In New South Wales government had reported that in 2014, 18,902 people were screened for mental health problems, and approximately 10% of them were referred for comprehensive mental health assessment. The reason that mental health disorder offenders shouldn't be in prisons. Prison environments is not suitable for mentally ill clients. Prison environment has lack of proper treatment, unable to afford treatment in prison. For example, Mental Health Act cannot be enforced in prisons. Mental disorder offender clients at risk of deterioration in their mental state due to non-compliance. Mental disorder offender at risk of verbal, physical, emotional abuse by their inmate. The routine in custodial facility not suitable for mental health disorder offender. Mental health problems can be compounded by sentencing practice. Longer sentence contribute to problem of recidivism, thus endless cycle start. The Queensland government is attempted to address the issue by establishing mental health crisis intervention team. However, in Queensland, it is clear that forensic unit at John Oxley Wilson Park is overcrowded and not generally available for women prisoners with serious mental health illness who may benefit from its service. Am I born this way was a question asked. The answer for that is environmental and genetic factor are two key factors that contribute to mental health illnesses. Psychosocial factor at times determine the level of risk of criminality in mental health clients. Please remember, not all violent people are psychotic. Paranoid ideation has a strong link to violence behaviors. Definitely, untreated mental health issue can result in criminality. Individuals with a history of incarceration were more likely, twice as likely, to report experiencing mental health illness in preceding 12 months than individuals who had never been in prisons. I hope you had learned in some way from my presentation. Thank you for listening. Lastly, please keep in mind that people with mental health illness are vulnerable in society as well as in prison environment.